So thanks, Richard. That was a great start. So I'm going to speak now about a talk I call Tips of the Trade. So Richard mentioned many things that I have in this presentation, but I'm going to show you kind of how they look when we're actually doing the scans. And I think that's a bit helpful. So it's too bright up here. So tips of the trade, how do we do terrific ultrasound? And Christina Merrill is my charge tech, who I really love a lot. So we could talk about the microbubble contrast agents, the ultrasound machine, and the contrast-specific software. But so when we're talking about liver masses, which of course is the approval in the United States, we're talking about both characterization and detection of masses. And so we're going to talk on the equipment a bit, touch on the technique, touch on the patient, and also on the masses that we're looking at. And so as Richard mentioned, we're looking at basically techniques that involve at least pulse inversion, although there can be multiple other variations of this at this time. And it's very important that we consider that we want to create a contrast-only image where we attribute all the echoes that we see in the field to the presence of the microbubbles. And of course, he also emphasized that we have an excellent subtraction technique which removes the background echoes. So I thought I would just show you one of the very first cases that I did with Peter Burns. And although we're not to ever have equipment logos on our machine, I left this one on because you people will see that this is on an ATL ultrasound machine. So this is really historic. This is not, the pulse inversion wasn't even implemented yet, and ATL was not purchased by Philips, and this is the machine. So this was a young man that was sent to me, and he was a university student with this liver, with this great big mass. And so, of course, at that time and today, we would still look at the mass on grayscale, and we'd look with color Doppler, and we can see there's both some lesional and perilesional vascularity. And if we add a microbubble contrast agent, so this was Peter and I, and he injected this contrast. And so when we looked at this, I was just horrified. I thought, oh my God, are we going to really do this, and what will we ever get out of this? And so I remember standing there just dumbfounded thinking, oh my God, there's no future. And so then, of course, we only had harmonic imaging on the machine. And so as soon as we flicked on the harmonic imaging button, you can see immediately that even though, so this is a scan that was done in about the year 2000 probably. This is an old scan. And so there I was standing only moments later looking at those beautiful vessels, and you can see those hairpin turns in the corkscrew vessels, and you could appreciate immediately what great capability was coming to us with contrast ultrasound. And that resolution is something that's still just an absolutely inspiring part of what we do. Now, another thing about the fundamentals, let's just talk about this, it's very important as well. So here's a patient who comes to us with a big mass in the liver, and you can see it's an echogenic mass, and it has a hypoechoic halo. So we're thinking this is a bad mass, just looking on a regular high MI grayscale image. Now, when we're going to inject the microbubble contrast agents, we use that subtraction technique that Richard very nicely described. So when we put on that subtraction technique, you can see that right before we inject the microbubbles, our pre-injection image is quite a black image. So not only has the liver disappeared, but that very bright echogenic mass and the hypoechoic halo, they've also disappeared. And so the observations that you make right at this point are really critical, because the ability of the machine to suppress the soft tissue is related to the nature of the makeup of the mass. And so what do I know by looking at that mass on ultrasound, not using CT or MR sophisticated techniques, but the only echogenic tissue which we can't suppress, what is that going to be? Yeah, but from fat. So in other words, so this mass is very, very echogenic, but it's completely suppressed. So in my mind, I'm thinking this is a mass that's echogenic, but it's not echogenic because it's made out of fat. So the thing that you have trouble suppressing is fat. So there's our picture before we inject the microbubbles. And then we always store the peak up to the peak of the arterial phase on a clip. And when we look at that peak image, you can see that there's our mass. And again, the mass appears white relative to the liver parenchyma. So we're looking here at a bubble-only image. And so all the bubbles that are in that image are related to the volume of the microbubbles, and the intensity of the signal is in proportion to the amount of bubbles. And so what do we know about this mass relative to the adjacent liver? Well, the mass is now whiter than the liver again. And so that means that the volume of microbubbles in that mass are in excess of the microbubbles that are in the liver parenchyma. And so they both have blood supply, but the blood supply to the tumor is bigger. So one of the big comments that we make when we're doing contrast ultrasound is how is the mass enhanced equivalent to the liver, less than the liver, or as here, is this a hyper-enhancing mass? And so when you're reading literature on ultrasound masses, ultrasound evaluation of masses, you'll see the abbreviation APHE, arterial phase hyperenhancement. And that's such an important observation. So many masses have it, benign and malignant masses. But there we can see that at the peak of the arterial phase, the enhancement is in excess of the liver. And then we keep watching perhaps for many minutes. And in the portal venous phase, we can now see that the liver, which is perfused by the hepatic artery and the portal vein, it's now become brighter than the mass. And the mass looks like it's washed out. And so that phrase that we say, washout, is such an important observation. We can see this here. And again, this is a bubble-only image. So we're looking at bubble images once we inject the contrast on top of a successfully subtracted mass. And so as Richard had mentioned to you, that observation of washout, it's not 100%, but overwhelmingly, as soon as we see washout, the first thought that comes to our mind is, this is a malignant mass. So lots of information. And again, this is on an old scan from the year 2000. And so I'll just go past that. Now, so let's look at a more current scan. So this is a patient who has risk for liver cancer, has HCV cirrhosis. And on our surveillance scan, we can see an echogenic nodule. And as we look at the contrast scan, you can see that on time 0, hey Richard, give me that lozenge. So again, you can see that the liver's gone away and that the echogenic mass has gone away. I'm not sure how we're going to get to 5 o'clock today, but oh, lots of water everywhere. So again, the mass is completely suppressed and the liver is suppressed. Now, you can see here that only 15 seconds, so we start the timer right when we say starting the flush. That's when the contrast is arriving. So you can see that that picture that's completely black has gone from completely black to showing again a mass that has arterial phase hyperenhancement relative to the liver parenchyma. And so if you consider, how many of you are radiologists that are watching this right now? Lots of you. Well, lots of you. But if you consider comparing this to a CT or MR scan, you will know that at the baseline, a CT and MR scan do not start out with a black picture. They start out with a picture. When we're looking at MR, they're using vibes, so you're using a T1 imaging. So the liver has got considerable echogenicity or considerable intensity. And so then when we inject the contrast, we see that the lesion goes bright as it does on the contrast ultrasound. However, only in ultrasound do we make such a dramatic difference between the pre-injection scan and the post-injection scan. So what does this explain to me? This explains to me why ultrasound has got greater arterial phase sensitivity to its tracer than does CT or MR scan. So they start out well up the scale, and then they change very little, whereas we start at the very bottom of the scale and we change a lot. And so that's a hyper-enhanced mass at 15 seconds. So then we start our intermittent scanning to find out what happens to it. And at 2.5 minutes, so that's regarded as late phase, we can see that the mass is again washed out. It's less than the liver. So that gives us tremendous information that's very specific to the diagnosis of hepatocellular carcinoma. Classic enhancement for HCC. And if we watch this, this is how it would look on the video, on the little clip that we would store. So we want to store from the arrival of the first bubble right to at least the peak of the arterial phase enhancement. And so this incredible ability of ultrasound to perceive these oscillations of the microbubbles is incomparable in any other imaging. No technique has that great of a difference from the baseline to the peak as does CEUS. And then just showing washout, here we're looking at a continuous injection where we can see the two masses, they're both hyper-enhanced, and then before our eyes we see the washout. So the lesions are hyper-enhanced and then they show washout. And so the reason we would record a little longer, as we have on this clip, is because we anticipate, because of the patient's history and also because of the multiplicity of lesions, that these could be met. So we record a bit longer so that we can actually watch the wash-in and the wash-out phase all within a single clip. Now, when we're doing these scans, as Richard mentioned, we really absolutely must have dual screen display available to us. And this is important, most important, when we're looking at small nodules in a cirrhotic liver. Simultaneous ability to put calipers or markers on both screens is essential. And so we've done many, many different little evaluations in my own department. And if you watch a screen and you inject the contrast and you know there's a little mass in the liver, you can think that you're looking at that little mass, whereas unless you caliper and actually confirm that what you see on the grayscale is what you see on contrast, it may not be that little mass. So it's essential. And then the timer is very important because on CT and MR scan, we tend to use arterial phase, portal phase, and late phase as descriptive terms for broad intervals of time. Whereas on contrast ultrasound, we're going to record everything that we record in terms of what that timer says. So we're not going to say this happened in the arterial phase. We're going to say at so many seconds we saw arterial hyperenhancement, and at such an interval, 90 seconds, 2 minutes, or whatever it is, we saw washout. And this is because these time intervals are specifically discriminatory as compared to the more general ones we have on CT and MR. And so here you can see we're looking at a mass that's hyperenhancing, and on our dual screen you can see that we've placed the calipers on the mass as we saw it when we injected the contrast. And we're doing focused exams on contrast ultrasound, again, as compared to CT and MR, where they're going to give you a picture of the whole liver, regardless of what you're interested in, which is terrific for them. But we don't have quite that advantage. But we do have the advantage of being able to precisely localize what we're looking at and then make sure that the enhancement that we're interested in does correlate, in fact, with where we've placed those calipers. And the timer should show on your picture. And this is just, this is one of the vendors that's here, one of our sponsors. Many people have better and worse places for the timer and the calipers. Now, what do you do if you don't have these things? Well, so this is really a provocative question. But in my own mind, if you don't have on your system the capability for dual screen with markers, you just should not be doing CEUS of liver lesions, especially nodules in a cirrhotic liver. So you must not characterize nodules. Now, about the equipment. So beyond the scope of this seminar, what are the other things that we talk about with our wonderful sponsors and vendors? Well, first of all, we're always interested in bubble resolution. And so I know that one of the companies who is represented here, but this was a long ago comment. I made a comment in a meeting after looking at showing a scan and saying how beautiful the scan was, and it would be perfect and even better if the bubbles didn't look like beach balls. And so that company has now really looked after that, and they tell me still, they know I said that in the past, they make a point of telling me that their bubbles are exquisitely resolved now, and that's true. And so we want to have excellent bubble resolution, and we want to have excellent near field resolution. So all of you are aware that oftentimes ultrasound machines, and still today I'll show some cases where we'll have a big bang in the near field. We don't want that big bang in the near field. We want to be able to see the liver capsule perfectly on every case. Now, in addition to having excellent near field resolution, we want to have excellent penetration. And so, as Richard mentioned, it's kind of been a good guideline that 10 centimeters is about how far we've been able to go. And so again, some of the people that are here, some of the newest equipment that's out really makes claims to go much, much further. And of course, the amount of penetration we have is influenced by the person that you're looking at. So if the liver is fatty and very cirrhotic, your penetration might be, in fact, much less than 10 centimeters. It may be only 5 or 6 centimeters. And so we want that penetration. We're always after the penetration. And then we want this thing called bubble preservation. So some of the machines that I have them in my own department. They're excellent, but they gobble the bubbles. And you don't want a bubble gobbler. You want something different than a bubble gobbler. So all of these things are things that are beyond what we're going to look at here, but they're just so important. And so we're always looking so carefully for these things. Now, as Richard mentioned, so one of the things that I really love, and one of the first ultrasound machines that was great for doing contrast was in fact the Accuson Sequoia, not when it was owned by Siemens, but when it was just the Accuson Sequoia. And what I loved about that machine was that someone came and showed me almost nothing, and you just could push the button to put the contrast on, and then do the scan, and it didn't matter really what you did. It didn't really matter whether the focal zone was in the right place or the wrong place. It didn't matter what you did. It worked well, and it showed excellent discrimination of masses from the background liver. Now, some of the machines, as we've advanced and got better and better and more beautiful technology and more beautiful monitors, everything, they have more complex buttons. And so then I became more concerned the other way, that although things might be improving, that then I couldn't turn on the machine and get it to work. I had to go and get my techs and do this and that. And so one of the things that I always try to stress when I'm talking to the vendors is that I want to recommend to people like you, as you did, Richard, that we use the default settings. Like, in other words, when we turn the machine on and we go to what you recommend we use with your machine, I want that to work, and it does usually. So we want to have presets for our exams. And so now I have presets for, like if I have an abdominal probe, I have a preset that I use if I'm going to do a standard liver, and a different preset if I'm going to look at the bowel. So we have things optimized. We do this with our application specialists. And so these are all very valuable things. And as Richard mentioned, we want to avoid the temptation to inject more contrast. However, I've modified my thinking on this over time. So if we have a great big patient who really does have a high BMI and we're trying to go deep in the patient, Peter Burns would always say to me, Stephanie, if you give more contrast, you get more attenuation. So it's a vicious circle. You might get more enhancement, but you also get more attenuation. But nonetheless, within reason, we do up the amount of contrast we would inject once in a while, and really avoiding the temptation to turn up the MI. We hardly ever do it, but with experimentation on 2 of the machines I have right now, if we're looking really deep, we do better with 1 click up on the MI, but just 1. And so this thing about the default settings is really critical. Now, what about the patient? Well, so we take any and all patients. And so although obesity is a relative problem, it's not absolute. And I'm going to show you a really good example. Uncooperative patients are, in fact, probably worse than obese patients. And breath suspension, Richard mentioned this, you want to really practice ahead of time. And don't think that if you have the patient, you've been scanning them for 10 minutes to look at their liver mass, and then you get everything all set up for contrast, and that's the first time you ask them to hold their breath. They won't do it properly. They just won't. And if you ask them to take a breath in, and that's the first time you've asked them, they won't do that properly either. And if you want them to breathe just normally, you have to tell them you don't want them to change their breathing. Otherwise, as soon as they hear you say, inject now, and then the nurse says, injecting, end of injection, starting flush, the patient's heart starts to beat faster, they start to breathe faster. You've got to practice so that they know. And sometimes I have a thing I do with my nurse where I go out of the room and I speak to her. And it's usually when we're getting more contrast because we've had absolute failure to this point. And I say to her, when I just raise my hand like that, you inject the contrast, but don't say I'm injecting the contrast, because some patients will react. So you've got to practice. And certainly I'm a person who's really madly in love with my sonographers. They just do such a great job for me. They do phenomenal jobs. And when we teach them, I always tell them, spend more time getting ready to do the contrast than doing the contrast. And if you're ready and the patient's ready, it will go perfectly. And if you're not ready and the patient's not ready, it may not. And certainly, suspended respiration in neutral is usually the best. So you'd have to practice with the patient again and just say to them, no, I'm just going to tell you to stop right now. And then they'll practice with you. They'll understand. Otherwise, if you say stop breathing, they'll take a breath in and then they'll stop. And so you have to make sure they understand. And certainly, we do use full suspended inspiration, but it's very difficult for the patient to maintain. You can't see your dual screen as well. And suspended expiration is almost impossible for everyone. So really practice and make sure your techs know this before they get started. Now, this is just a little hepatocellular carcinoma, and I want to just show you this. So there's a grotty little liver with a hypoechoic mass we see nicely. We can see that it's hyperenhancing in the arterial phase, and then we can show that it has washout. So the scan was a great success. And this is a great success on a patient who's had 2 MR scans that were both interpreted as uninterpretable. So this was gross motion artifact. And so when we lose this patient, so I don't know whether we said to the patient to stop breathing, or the patient doesn't understand, or she doesn't want to stop breathing. But the point about ultrasound is that although breathing is an absolute death knell for an MR scan, breathing really doesn't usually hurt us. And so one of the very best ways to do a contrast ultrasound is such as here, where we can really get right on top of the mass. We can sit nicely on it. And although the patient is breathing in and out, she's comfortable. She's not bothered by us doing the scan. And we can see the mass absolutely beautifully. So in most patients, a normal amount of respiration is not problematic. Now, there are many patients that we see that are much more difficult though. So this is a patient where we spent a great deal of time trying to have the patient stop breathing and ultimately decided that was completely impossible. So then we're trying to find a tissue, a plane where we can actually see the lesion coming in and out of our field of view. So you can see those nodules on the left-hand grayscale image, and you can see that when we inject the contrast, that we can see that mass in spite of the challenge of doing the scan. Now, as Richard mentioned, the sagittal plane is generally the best. And so if my techs ask me, how should I do this? And they show me a beautiful axial and a beautiful transverse picture of a mass, I will always say, let's do the sagittal scan first. If it's perfect and you want to do the transverse, then you can go ahead and do it. But the sagittal plane, you can see that there's a big mass here, and the patient's a very nice quiet breather. But as the patient breathes, you can see that the mass is always, you can follow it with your transducer very easily when you're in the sagittal plane. Whereas that same big mass, every time the patient breathes in and out, you can see that the mass goes in and out of your field of observation. And so it doesn't matter how small or how big it is or what you're doing, the sagittal plane is definitely usually the best. Now, you want to also explain to the patient, especially if you have ethnic patients or people who aren't really in sync with you, you have to explain to them what you want them to do. And you have to tell them what you expect them to feel. And so many patients will come in and they'll say, oh, I had a big reaction when I had a CT scan, or I had a reaction to this or that, and they're anxious. And so I say to them all, I say, really, you don't need to tell me what you've had before, because when you have this contrast, it is very likely that you will feel absolutely nothing. And so you want them to be reassured, and most patients are very reassured and do very well. You want them to understand how you want them to lie, if they're lying flat on their back, supine, or way up sharply in the lateral decubitus, and you want to tell them how you want them to breathe. And very, very important, if you're in a tertiary institution where they're doing ablations or using ablative procedures on the liver, you want to make sure that all these things that you did to make the scan beautiful for you to take the nice pictures of the mass, that you put that into the report. Because then when our interventional radiologists go to do the scans, we're famous for this. They say, well, Stephanie can see it, but nobody else ever could. And so, of course, it's not true. And if we tell them how we saw it, they can reproduce what we're doing. And then in addition to that, they invite us to come. So we're actually always there anyways. Now, prior to performing the scan, you want to take as much time getting ready as you do performing the scan. Determine the optimal scan plane. Long axis minimizes out of motion plane due to respiration. And you want to always place the nodule in the center of your picture. And I can't tell you even to this day how often my technologists will work, but finally they like the picture where the mass is way over onto the side lobes of the image. And it's not as good over there. It's always better if you can make the mass be in the center and the beam coming right perpendicular right at it. So you don't want to be taking pictures. We get them all the time and we use them, but they're hard. Now, when we're doing a scan, on ultrasound, we're generally focusing on a visible nodule. And there's a few comments that I'll make. So the threshold size that we should consider as a good rule of thumb is to scan nodules that are 1 centimeter or greater. Now, do we scan nodules that are smaller? Of course, and we scan lots of them. But many times when you get referred a patient, let's say that has a cirrhotic liver, that has multiple nodules everywhere, if it kind of looks like the background tissue, it's a very good help for us to be able to say 1 centimeter is a guideline. Let's wait and watch these until they get there. So it's just a rule of thumb. And do we ever scan looking for arterial phase hyperenhancement from CT or MR scan that we don't see on ultrasound? This is a very big, very common question. In other words, CT and MR show something, we know it's hyperenhancing on their test. And so if we don't see a nodule that corresponds, should we do an ultrasound just firing at that area by triangulation, picking landmarks? And so the answer is yes, we do. Now, and so we do it a lot in my department. However, this is something that you're not going to do the first month or 2 months or 3 months that you're out there. You want to have a good lot of experience before you try shooting to find a mass that you don't see. So valuable, but not for the beginner. And so parenchymal change, I'll just show these couple pictures. So both of these patients are patients who were sent to my department for a CEUS. And so when I look at them, they're quite different, but we didn't do CEUS on either one. Now, so the patients on the bottom right, has got a liver that's filled with tiny hypoechoic nodules. But so that, in my mind, I interpret as the background parenchyma for that liver. So consequently, nothing looks dominant to me, nothing looks suspicious. And so what are the things that make a nodule suspicious? Well, in that liver, it would be a nodule that's bigger than those ones. Like, so all those little ones that are in the background, if there's one that stands out that it's bigger. And then the next one is that these are hypoechoic nodules. And so like if one of them is blacker, so like a blacker nodule that's bigger, then we'll scan. Now, the upper left image is a little harder. It's kind of more coarse, more variation. And you might kind of say to me, well, could there be a nodule? Can't get my little mouse to come on there, right in the middle of the picture there. There might be. But so if these nodules come from an outside surveillance scan, like a facility that's doing surveillance for HCC, if they send it to me and they're worried about something, then I always do the CEUS. But I do the CEUS for political reasons more than medical reasons, because I want to send it back and to be able to say that we think that the baseline did not justify doing a scan. However, it was done. We've done portal venous and arterial phase sweeping of the liver. We don't detect hyperenhancement and we don't detect washout. And actually it helps me too. It's reassuring. So now I like it better. But so size threshold is important. Now, what about echogenicity? So here's a patient with an echogenic nodule, and here's a patient with a black nodule. Does it make any difference which one of these we should do a scan on? It really doesn't. So there can be benign and malignant things that are black and benign and malignant things that look white. And so if the patient was a non-risk patient, everybody knows that. We all make the assumption that some nodules are hemangiomas, but those are always to be inferred or guesstimated only on a patient who doesn't have risk that they actually have cancer. So they can't be at high risk for HCC, and they can't have had a previous cancer of any kind, particularly colorectal. So both of these require contrast ultrasound. Now, and I'll just show this one reference, which is so important. This is a reference in the Italian literature. So there's a little mass in that liver, and so I'm sure all of you who do sonography know that we see that kind of mass day in, day out in people scanned for other reasons where it's incidental. And we say, well, that's probably a hemangioma. But in patients that have a risk for HCC, we have to presume that that could be an HCC. And so in this big study that they had, they looked at almost 2,000 patients with newly diagnosed cirrhosis. And in these patients that had a hemangioma-like nodule, 50% of them turned out to be HCC. And then the thing that I think is even more important, because I've seen this so often after I read this manuscript, is that again, in another population with patients with known cirrhosis who are undergoing surveillance. So in other words, these are patients that are going to come back every 6 months to have surveillance. If you see a new echogenic nodule appear, it will be HCC. And so many years ago when I read this manuscript, I did a patient that we'd been scanning for years and never seen a thing, and we saw a new echogenic nodule in her liver. So I quoted the reference and I said, this is an HCC. And so of course, about 5 minutes later, I have this doctor standing in my office saying, Stephanie, you must be going crazy. You can't tell it's an HCC on an ultrasound for sure. And I said, well, I think it is. And so it turned out to be, which was the great thing. But it's been a very helpful rule. But I always show that to people because if you're going to do ultrasound with CEUS and you're going to be the person that's out there deciding, is this a scan I'm going to take to my boss and say, let's do a contrast, you have to know what are things that you should be looking at. So that's one of them. Now, what about lesion depth? So lesion depth in general, greater than 10 centimeters becomes problematic. And I have not had the opportunity to use the famous big probe that's out there now that says it's going to go to 15 or maybe 20, but I'd be so delighted if it does. Now, in the patient with a fatty liver, it can be even less. And as Richard showed, you want to always move the patient so that you make the depth from your transducer crystal to the mass the least that it can be. Now, so we always start supine, and then we go to left lateral decubitus, and then we try other maneuvers, and then we document any special success. But so this is a very good example. So this is a patient who's 48 years old, has a previous breast cancer, and she presents to emergency with abdominal pain. So not things related to her liver, really. And so they see this deep echogenic mass in her liver. So that's well over 10 centimeters, and she's quite a big girl, and her liver looks quite nice. But so when we turn her into left lateral decubitus and we go intercostal, you can see that we've made the depth of the mass less than half of what it was when she's lying on her back. And again, you can see that we've worked hard to put the mass right in the center of our image so that we're not working in the side lobes, we're working right in the center of the image. So then when we come to do her scan, we're in that position, left lateral decubus, you can see. And the lesion is instantly hyper-enhancing before her liver enhances, and then before our eyes, it goes black. So we know that this is a rapidly enhancing solitary mass in her liver, and that it goes black almost immediately. And so that is a mass that tells me this is a malignant mass, let's do biopsy. So now someone might say to me, well, why wouldn't you recommend for them to do a CT or an MR? So I could. And of course, even if I don't, the doctors probably will do it anyways, which is fine, but I'm not going to recommend it. So we say to do a biopsy. And so even if they do the CT and the MR scan, they will not know what this is until they do the biopsy. So where we're headed is to the biopsy. And so if they want to do the CT and or the MR, that's fine, but they won't get the answer until we do the biopsy. So this lady did have the biopsy, and when she has a biopsy, she has a metastatic carcinoid tumor. And so this is a totally unsuspected, unknown tumor. And so this is a very valuable ultrasound lesson. Now, what about another patient? So this was a patient that my technologist came and said to me, maybe we shouldn't do this patient. And of course, I've already said to you, I never turn down anybody. It doesn't matter, even if they weigh 300 pounds, drink too much, and are not totally cooperative. So the patient comes, and so I said to my tech, just do the best you can, bring it to me so that I can at least see, maybe we'll do contrast, maybe we won't. So they bring me this. I thought this was quite a beautiful picture on a 300-pounder, actually. And the mass is so big that we should have a chance of getting it, even though it's well over 10 centimeters in depth. So when we, sorry, I'll just come back to that for 1 second. So this patient also wouldn't lie down, and he's sitting on the edge of the bed. So these pictures are taken sitting up on a 300-pound alcoholic. So we still went in and we did the contrast. So when we inject the contrast, you can see that yes, we get better enhancement of his liver, but even though that's such a big mass and such a deep mass, we can actually see very, very well that that's an enhancing mass lesion, and it goes down to 15 centimeters. So in the proper circumstances, we can go much further, especially if we're going through reasonable liver. So we can
Stephanie, question over here.
Oh, yeah.
Are you in the room with the patient and the sonographer? Were you at the beginning in the room? Because I know I've talked to a number of people who say, well, I want to be there when this is being done. So where do you sit when these studies are done? And where did you sit when you started?
So when I was in Toronto, so I left Toronto in 2007. So when I was in Toronto for the first several hundred scans that we did, Peter Burns, who's the world-renowned physicist, some of you will know him or know of him, he came and I did all the scans together. And Peter doesn't draw the limit of him participating, that he's a physicist. He thinks he should be fully in there. So Peter and I did all of them together. So I did all of the scans myself. And so then as we got more into clinical things, and still at the Toronto General, they book the physician to do contrast enhanced ultrasound. And so they have a physician there, that's what they're there for. They have someone to start the IVs, and so they do all the scans. Now, when I went to Calgary, that's what I thought I would do as well. Recruit a nice radiologist to work with me, and that I would have someone come and we would do scans like that. It was not very long after I was there, and I realized not much chance of that happening. So I decided that instead I had to go after those techs. And so then I got first one absolutely sensational, and then two, and then more techs. And so now there's actually 5 technologists that are trained in my center where I am, which is a fraction the size of the Toronto General. But so my techs, originally I would get them to get everything totally ready, prepared, tell me if they wanted me to come in and scan with them, and we would look and plan things together. But as they've gotten more and more and more and more competent, and the truth of the matter is that they become more competent than you. So now we have enough equipment and we do so many scans that when we get a new machine in, now I've lost my motivation to become totally proficient on every machine. And so now my techs, they present to me what they're going to do. And then depending on how many scans are going on, sometimes we're doing 2 or 3 contrasts even at the same time, not just scans. And so then I don't always go in. So they know when to come to get me. They know, but they know exactly how to do it. But so this guy, I mean, sure, my tech that was doing this, she was anxious about this, and a patient that's so big and sitting on the bed, and what if he fell over, and all kinds of things. So I was in the room, Steve standing right there, breathing down his neck. But so there's our arterial phase pictures. And then you can see that at 1 minute, this mass is isovascular with the liver. And these are beautiful pictures on a big patient that we're persevering. And just very quickly, that mass shows washout. So not only is it a reasonable scan where we can make an opinion, we can actually make a better opinion. So that's a proven hepatocellular carcinoma in that absolutely enormous patient. And of course, patients get so big, as you know, that some of them don't fit into CT and MR gantries either. So that's not a slam dunk that you can always go to CT or MR scan. But so you can see this increasing in washout. And this is a very typical appearance of washout where it's originally weak, like on the left-hand image where there's still bubbles left inside the washout area, or it can go completely black. So that is HCC. Now, I'm going to leave this. I'm going to go through this, and I'll show this to you after. But I'll just show you this. So this little table right here is a table that looks at the arterial portal and late phase, and it kind of gives rough intervals that are deemed to be appropriate for when it starts and when this ends. And so that's for the arterial and the portal and for the late phase. And so the arterial phase, from as soon as we see a bubble, till about 20, 25, 30 seconds is perfect for the arterial phase. And the portal phase goes to about 2 minutes. And then the late phase is everything that's left. And so certainly if you're looking at patients where you might be looking at an HCC, you have to look for a long time, at least for 5 minutes. And this is the graph which Richard mentioned. So Andre Lyshuk and I are both on the LIRADS working group. And so this is something that we made for that. And so what we're talking about here is, you can see on the left side, I don't have my mouse working on here for some reason, but the line that says recorded. So what's required for us to record is we want to always put on our record button right when we see a bubble in the field of view. And then you want to leave it recording until you're past the peak of the arterial phase. Not a long ways past, but so usually our clips are somewhere between about 10 to 15 seconds. We're not trying to record a continuous minute, because the more that you're watching and then recording, not the recording, but the watching, the more bubbles you're going to gobble up. And so after we're satisfied, then we turn it off. And so then you can see, so the required line there for the recording, and then you can see that all those little lines that are up and down on the upper part of the graph, they're the intermittent scanning that we do. So we either look at every 30-second intervals or 60-second intervals so that we can see what happens. And what are we looking for? We're looking for washout. And so that's what we basically do. Now, so what imaging do we need? The wash-in, and then record as a continuous acquisition. And then you'll see in the other presentations that I give, I really pride myself on taking the most beautiful pictures. And so what I've learned over time is that the beautiful pictures that we take, we don't take them by doing a lot of it. The machines today, you can take pictures on the fly. But taking pictures on the fly from contrast is not as good as taking grayscale pictures on the fly. And so if we record a beautiful wash-in, the beautiful pictures that you're going to get of what's happening to those vessels and that tumor along that pathway, you're going to get by backing up inside that AVI clip. You know how you can do it frame by frame? You're going to look frame by frame and pick the frame that you like the best and store that as an image. And always store as a still image the peak of the arterial phase enhancement. And then you're going to do your intermittent imaging. But so here, this is just a clip that I made a long time ago, but you can see that when we're watching the microbubbles come in, you can see that we see the artery and we see the portal vein fill, and you can see how beautifully we can actually record the enhancement of the vessels, and that we can see, in fact, the timing of what's going on in the liver. And so right here, this is just a regular patient. And so if we line up pointing at the porta hepatis, you can see how beautifully we can see first the hepatic artery enhanced and then the portal vein. And so if I just let that start again, so when the contrast comes in, you saw the very bright hepatic artery, which is small, and then at about 15 seconds, you can see that the portal vein is starting to come in, and then the parenchyma starts to enhance. And so that kind of imaging is what we can get. So there's our arterial images, and then we can see the portal vein at about 15 seconds, and then the parenchyma is there more 15 to 30 seconds. And so when we were looking at that little mass on the lady with the metastasis, for example, oftentimes, if we're looking at a hypervascular mass, it will enhance. It's totally fed by the hepatic artery usually. So it will enhance when the hepatic artery enhances. So it will be bright on the liver even before the liver has evidence of enhancement. And so these are just the evidence of the beautiful resolution we can get just looking at these vessels as we inject the contrast. I'm going to go past this. Brief incidation every 30 to 60 seconds, looking for washout and sustained enhancement. And then additionally, we want to always do sweeps of the liver. And we're going to do sweeps particularly in the portal venous phase, and we're doing them to detect occult nodules on baseline. And I'm just going to go past this as well and go to that. Okay. Now, so when we look at this patient right here, here's a patient who again has got multiple nodules in the liver. So we're thinking that this could be metastatic disease. So when we do our contrast injection, this is a place where we might go longer than just to the peak of enhancement. So there we can see that our nodule has enhanced with a rim enhancement pattern so that the center is black. And then as we go further, we can see that before our eyes, that nodule, that rim has now washed out. So the nodule is black inside. And so so if we anticipate metastases, we always take that 1 minute image, but we sometimes record right through the scan. So now in the portal venous and late phase, we do sweeps of the liver, and suspended respiration is best here. And so we want to look everywhere, and we're looking for washout. So here's a patient that's taken a full breath in, and we're looking at their right lobe of their liver. We still leave it on dual scanning, and so you can see that we can see beautiful uniform enhancement of the liver parenchyma. And if there was any areas of a black spot in the liver, so oftentimes we pick up metastatic lesions doing these scans. So these are often unsuspected metastatic lesions, or they may be other things, but especially metastases. And then this is the kind of left lobe sweep. And again, the patient has a full suspended inspiration, and we can see that beautiful homogeneous injection enhancement. Now, injecting on top is something that's a very, very valuable technique, so I will show you this. So when do we use this? We do it when we see unexpected washout on the sweeps. So in other words, we do a sweep and we see a black hole in the liver that we didn't know was there. So now if we come out of contrast and then we look on our grayscale scan, if we come out immediately, then the black hole is gone. And when we go back into contrast, the bubbles will be destroyed. We won't see it anymore. So injecting on top is the best way to find out what that mass did originally. So we are usually injecting in the late portal or late phase. And so let's look at this patient. So this is a 61-year-old male who has a prior squamous cell carcinoma of the tonsil. And so he has one observation on his scan, and that is that on the sweep, we can see that very deep but black hole in that liver. And so the baseline is normal. So we think that this is possibly an occult tumor. So when we inject on top, this is quite a challenging scan. So you can see that at 8 seconds and at 9 seconds, that nodule still looks black. So we're looking right at it. So when we're injecting, we're not moving around. We're sitting right on our area that we're looking at. And so at 11 seconds, you can see that the microbubbles are filling the rest of the liver. So we can see little bright flecks of contrast in the hepatic arterial branches. But now we can see at 11 seconds, it's starting to enhance. And at 13 seconds, it's gone. We don't see it anymore at all. So we know that this mass is enhancing, right? So we know it's not like a cyst or something like that. That's nothing. We know it's enhancing. So we keep watching, and again, at 25 and 27 seconds, bang, it all of a sudden comes back. So what do we know? We know unequivocally that that is a metastasis. Now, how often do we do scans like this kind of thing? Surprisingly often, and so Richard had mentioned about looking for metastases. So what I feel about looking for metastases is this. If you consider the big cancers that our oncology departments are filled with, it's colorectal cancer, lung cancer, and breast cancer. Those are the big cancers where the patient has a high likelihood or a high risk for developing metastatic disease involving their liver. So all of those major big cancers, they all have protocols that are adhered to all over North America. So they're the same where I am as where you are. And so every so often, 6 months at the beginning of the patient's post-treatment interval, they have a CT scan. And these CT scans are performed almost without exception in the portal venous phase only, looking for metastatic lesions. And so ultrasound departments don't have the capacity to look at all those hundreds of patients that come from the colorectal, the lung, and the breast cancer clinics. But what happens is the clinicians, the medical oncologists, they will have patients where they're planning a treatment regime, and then they'll get a report. And what does the report say? It'll say new low attenuation mass in the liver of small size, or multiple low attenuation masses of small size. Please confirm that these are metastases. So for solving problems in that population, CEUS is great. And my medical oncologist will stand right up at a meeting and say, Stephanie solves countless problems for us that used to delay our initiation of their treatment plan until they resolve whether the patient did or did not have a MET. And these lesions are often indeterminate on CT and MR, whereas we can resolve them. So this is one thing that happens. And I don't think I'm showing you other ones, but we know because those bubbles come in, that is a metastasis. And so ultrasound for problem solving in the patient at risk for metastases is really terrific to resolve those things. Now, I won't talk about the sonographer. We're obviously so far behind, I don't even know what to do. Richard, have you looked at the schedule?
Why don't we go ahead and take our break?
Okay, that's a good suggestion. Any questions about what we've talked about here? Yeah, sure.
So in HCC interpretation, I find the mild washouts sometimes difficult to be definitive about. And with LIRADs, you need to be definitive to have that 100% specificity. Sometimes, like, is there a washout, is there not? I find myself being a little wishy-washy. Do you have that?
Yes, of course. So the question, so in a situation where we're looking at patients at risk for HCC, and we're trying to follow the LIRADS guidelines, which of course are based on the observation, including that there's late and weak washout. So that's a really terrific question. So what has to happen, and this was something that I remember Peter Burns and I decided this years ago, and I've never deterred from this, is he would say to me, I think if we answer one question per injection, we're doing well. And so to this day, although we often answer many questions, we answer all the questions in one injection. If things are difficult, if you answer one question, that's good. So what happens in the circumstance that you're talking about often is that we see a nodule on the baseline, and it's a nodule that's potentially an HCC. And then we do the injection of the contrast, and we confirm unequivocally that it's got APHE. So we know that it's a hyper-enhancing nodule. But then here we are watching intermittently this crappy liver, and it starts to decline and it starts to lose its contrast and doesn't have that beautiful enhancement at 4 and 5 minutes that we want. And so then when you're trying to look, what's happening is that, yes, your nodule has definitely dropped down, but the liver enhancement has also dropped down so much that it's hard to tell whether it's got washout. So one of the things that we started to do years ago that I still do is that once I've answered the question that it's a small nodule with APHE, and we're worried about that late phase, is we do an injection already, like right on the nodule as always, but we don't scan. So we don't scan the arterial phase. So we allow the whole bubble population to be in the patient, and then we start to do our intermittent scanning at a point where we believe is a good place to start. So maybe like 2 minutes, for example, we might do our first intermittent scan. And so quite often then you improve the enhancement of the liver more than you do change what's happening to the tumor. So you want to try and see, and so that's something that we do. And then the other thing is too, is that if you do more than one injection and you're looking at a different nodule, if you know where the nodules are that you're interested in, make sure that you look at all the nodules in the portal venous phase, even the ones you haven't been looking at, because again, sometimes then you haven't been there bothering that nodule and knocking the bubbles out of that liver, so you'll see it there. But great question, thank you. Yes. Yes. Pardon?
What is the success rate?
For what? Yeah, but for... So Richard actually has got some literature analysis on, so the question I think you're asking me is what's the success rate? So I believe that liver mass characterization with CEUS is an absolutely sensational indication for the use of microbubbles. And this is not an easy thing to do. It's not so difficult, but it's not easy. And so with meticulous technique and a good conscientious selection of cases and, using the maneuvers and the things that we've tried to talk about to you, it's very high. And so the success rate is different, though, for every single thing. Like we have much bigger success rate, for example, for confirming things are hemangioma and FNH than we might for diagnosing nodules that are 1 centimeter in a cirrhotic liver. But similarly, CT and MR scan have the same problems there. And so resolution, Richard said this very nicely, resolution of indeterminate CT and MR is one of the really biggest and most valuable uses of CEUS. Yeah.
Just trying to understand, I get the wash in part, but what is wash out telling us? Why is wash out so important to that?
Did everybody hear that? So why is washout so important? Well, so that's one of the questions of the century. and it's been debated by everybody, right? Why does washout actually occur? So the significance of it, of course, is its extremely high association with malignancy. And so that obviously in many instances has to do with the fact that these are lesions that are fed totally by the hepatic artery. And so with microbubble contrast agents, where the bubbles stay in the vascular bed, then we're going to have washout as soon as we're no longer in the hepatic arterial phase. But that actually does not explain all washout. So washout is something that's recognized on all modalities, I believe. recognized as something that's very, very important for imaging interpretation, but with big questions about why it's actually occurring. Would you agree, Richard?
You know, I don't think we really know.
Okay. But as a sonographer, should we document washout? Is washout more important?
Washout is absolutely essential. And so what happened actually was when Peter Burns and I did a study originally way back in the early 2000s. And we had, I think, over 150, 175 patients. And so all of the data, this was a pharma-sponsored study. And so all of the data went from us to their statisticians. And so the statistician called us actually only hours after he'd started to plug all this stuff, put all the information was in the computer. And he says, there's one phenomenal result. And he said, the cancers all have that washout. And so that was how long ago it was that someone said to me how important it was. And so what was funny though was that when they wrote their own version of their interpretation of the results. And so it says, look at the washout first. Also, what the problem is, of course, is that you see the washout last. So you can't look at it first. I mean, it doesn't occur until the end. And so we can't do that. But nonetheless, the importance of it is made.
The reason I'm trying to understand is we just started doing the CEUS and from
Yes.
growth. So when we're looking for reflux, so we're only documenting the contrast going in if it's positive. So I'm just trying to understand. We never focus on once we document it, it's positive, it's there. We never focus on wash out.
No, that's a really good comment, actually. So that's a mechanical thing, like you're actually looking at a mechanical situation. And what we're talking about in terms of washout in a liver lesion is hemodynamics. And so it's quite a different thing. But here, okay, so Richard and I are going to reconnoiter about the schedule. And please have a coffee.
So, but in terms of her question, washout is really all we're doing intravenous injection.
Yeah.
That makes sense, yeah. Thank you.
Okay, perfect. Thank you all. So Richard.